Thank you. Well, thank you for having me here. It's a pleasure to be with you. For me, it's tonight. I think for you, it's lunchtime. Hopefully it's lunchtime. For us, it's dinner time. My name is Daisy Bassen. I am a child psychiatrist. And I work in a community mental health center. I did my undergraduate at Princeton. I did my medical school at University of Rochester, and I did all my psychiatry training at Brown. So I came to Rhode Island about 20 years ago, and I stayed. I did my adult psychiatry training and then my child fellowship here. And right now I work in a community mental health center where I work with children as young as about 3 to about 18. But I've worked in a variety of settings, including inpatient psychiatric hospitals, school consultation. What else? I did private practice for 7 years. So pretty much most of the different residential treatment. I've done most of the different kinds of child psychiatry treatment you can do. I'm also active with the Rhode Island Council of Child and Adolescent Psychiatry and do a fair amount of advocacy work. And actually the PowerPoint that I'm going to share with you tonight was originally designed to share with Rhode Island pediatricians in 2014. We did a local talk. It was prior to the Zoom age, so we just all met up. I forget where we were, but another child psychiatrist and I developed the initial prototype of this PowerPoint for our pediatricians. And I came back and sort of tweaked it a little bit and imported some things. I did some consultation with a few other child psychiatrists and pediatricians that I know to try to make it helpful for you guys. So with no further ado, I think I'll start moving ahead here because some of the slides are a little bit wordy. But I wanted to thank Dr. Jill Welty, Dr. Matt Willis, and Dr. Allison Brindle, who assisted me in creating this presentation. Dr. Welty and Dr. Willis are child psychiatrists. Dr. Willis is a triple boarder. So he's also a pediatrician. And Dr. Brindle is a pediatrician and the head of the Rhode Island AAP division. She and I are in an advocacy work group together. So I got some input from them. It was very helpful. So I wanted to give them a shout out as part of this. And in fact, I want to go over our objectives, which would be understanding the criteria for diagnosis of depression in a pediatric patient presenting to a pediatrician, or I guess a family practice doctor, how you'd work it up and how you might treat it. Most of my recommendations are sort of location independent, but I did manage to find through Googling a big packet that I think will be helpful because it was made specifically by Hawaii child psychiatrists in 2019, and that's included in the resources section at the end. So there are some more Hawaii specific resources that are included in this presentation, but I'm going to go over things in general that you could use and should be in any office. And I think we had to do this pre-test for the CME. So I guess I'll let you guys look at these questions for a few minutes and then you do a poll in some way. This is the magic of Zoom. I don't know what happens right now.
It is the magic of Zoom. So Summer's gonna set up the the poll questions for us. Here they are. And you, I think, get to watch us answer. I'm already failing at the first one. I don't know how anyone else is doing, but this is going to be a fun session.
About half of you guys answered. I'll leave it on for about 30 more seconds.
That sounds good. You guys are always good at keeping us on our toes. I think otherwise I would be contemplating forever. And then from here, we can go straight into the presentation and then we'll have the post questions to answer afterwards. And that's when you get to give us the correct responses.
Well, if I've done this properly, you'll know the correct responses by the end.
Okay. And the poll is closed.
Okay. people still answering, or am I moving ahead?
You can move ahead into the presentation. Yeah.
Okay. Okay, so I decided to just include a case to start. Actually, should I put it this way so that we can just have a sense. This was a case that was shared with me by Dr. Brindle, who sees children in her office. So she had a patient, a 14-year-old, who came in for a routine checkup, had lost 15 pounds since the last visit. The PHQ-9 screen was positive for depression and past thoughts of suicidal ideation. The transition to ninth grade had been difficult. The end of 7th and all of 8th grade had been virtual, right? It's pandemic. So the coursework in high school felt even harder. The patient was having a hard time identifying with a friend group. Patient had recently started identifying as gay and was afraid to tell her parents. Patient was open to therapy. Mom was open to taking her therapy because she's been worried about her. She was already on several wait lists, as I'm sure it's similar for you. We have a lot of wait lists around here now. Bridging the gap with the school guidance counselor, trying to give her some stuff in the meantime. And the patient and her parent have the clinic number in case of an emergency. So once again, pediatrician is sort of left holding the bag. So that's a case to keep in mind that I thought felt like my colleague shared with me a couple of cases. I thought that one would probably feel familiar to many of you. And I specifically chose more of an adolescent case because you are going to see more depression presenting in adolescents versus younger children. It'll be much less common for you to see really depressed kids under 12. Under 12, you're probably going to end up seeing more kids who are pretty notably anxious. So anyway, the DSM-5 criteria for depression includes depressed, irritable mood, depressed or irritable mood. You don't have to have both. And in a child or adolescent, it can be irritable prominently as opposed to depressed, anhedonia, weight loss, gain or failure to gain, increased or decreased sleep. You can be either agitated or have psychomotor retardation, fatigue, low energy, feel worthless or guilty, decreased concentration, and or having thoughts or death or suicidal thinking. You have to have, five or more for 2 or more weeks, and it has to include the mood changes, the depressed or irritable mood, or the anhedonia in order to meet the DSM-5 criteria. Where my clips go there. So in terms of doing a workup, some of this I think will seem fairly obvious. You would interview your patient. You're going to want to talk to the parent, probably separately. Sometimes they won't separate. I think if they won't separate, it's better to get them together than to have it shut down, but it's ideal to have them separate because patients will often tell you things without their parent present, and parents will often tell you things that they wouldn't want to say in front of their child. You're going to want to do a risk assessment specifically around suicidal thinking. We'll talk a little bit about labs, what kind of labs might be indicated, and screening measures, part of the workup. But the fundamental thing to know about a depression diagnosis is it's clinical. You don't have to do labs to make a diagnosis. Labs might be helpful for guiding treatment, and you don't have to do any kind of particular screen in order to make the diagnosis. I think more of the time now, insurance will end up, if you can document that you did a particular screen, you might be able to bill for it. So that's just a little, like, think about that in terms of, you might bring that back to your billing departments. If you can add that in, then you can code for it. When you meet with the patient, you want to ask open-ended questions about their mood. But then, depending on what kind of history they give you, if you need to sort of flesh it out, you're going to want to ask specifically about the timeline, when it started, how intense the symptoms are. I usually like to ask about whether a specific event or something happened that triggered it, or whether they just sort of noticed it, that's when it came on. Kids will often be vague, I find, about how long they've been depressed. So I usually start asking about, has it been this school year? Was it, use other data points like the holidays, since a vacation, depending on what's going on, in life, to sort of narrow it down. Parents will often think that depression started more recently. Kid will often tell you it started earlier and the parents didn't necessarily see it. You want to assess level of function at home, at school, and in social life. So they might look pretty good in one area and not in another. This might come to attention because there's a decline in school performance. This might be a kid who's might be doing okay at school, but seems a lot more isolative at home, or has stopped spending time with friends or doing activities. So it could be all of those things, could be any of those things, but you want to sort of look for those. You definitely want to assess neurovegetative signs and symptoms. So how are they sleeping? How are they eating? Energy, concentration. Sleep with teenagers is always like a big thing, right? They go to bed late, they want to sleep late. I don't know what time your schools start, but we've been trying to do a later school start around here, and that's still like a late school start is 8:30 in the morning, which is still probably not late enough for most kids. So you want to try to get a sense of, what's that looking like? how late are they doing homework until, that kind of thing. Appetite, honestly, I don't find that most kids talk as much about that. Maybe some of it, but that's usually you hear a lot more about sleep, energy, and concentration. Appetite is there, but it's not usually the one they complain about as much, unless there's a big weight loss or a weight gain, which can be part of it. You might hear more about concentration, about difficulty with schoolwork, or with other activities that are important to them that they can no longer focus on. It's important to note that in children and adolescents, anger and irritability can be the presenting mood symptom, as opposed to what people might more classically think of as depression in terms of sadness or hopelessness. So that can be tricky because haven't we all known irritable teenagers? And so how do you determine what distinguish between what sort of regular teenage irritability and what's more? So that takes a little bit of sussing out, but usually if someone's complaining about it to you, it's probably more than, an average teenager experience. Okay, so when you talk to parents, which you're already very good at, you're going to ask them how long they think things have been going on and what level of impact they're seeing in their child. Kids will either they can overemphasize how poorly things are going. They can minimize how poorly things are going. So that's why you want to have that other point of contact about what a parent sees. I'm of two minds about this sort of like no one knows their child better than their parent. I think parents have a particular insight into kids, and they often see things very clearly. But I don't think they're always necessarily the best person to report on how a child is doing. But, so I think you keep that in mind, and then you want to get their sense of things. They may tell you about stuff that the child doesn't tell you about as much. So they may have more of a sense about like the kids disengaging from spending time with us at meals. They rush up to their room. They don't want to spend time with their friends anymore. They stopped different activities they were doing. They stopped playing sports. It's also helpful to talk with the parents about any family history of mood disorders. And if they mention that someone's had depression, and I think specifically it's good to ask about postpartum depression, because people don't always think about that one in terms of being part of a depressive history, but it is. That's good to ask about that. But then if people say that anyone's been depressed, it's helpful to ask if there's any kind of treatment history, specifically if there's any medication that was used that was helpful, because that may help guide you down the road if you decide to move ahead with a med trial, to have some sense of that. You can also ask whether anyone's had a really difficult time with a medication, because that will give you a sense that if you bring that one up, they probably won't want to use it. So that might help you maneuver a little bit through that. Okay, in terms of risk assessment, what's the big risk we're thinking of with depression? It's suicide. Depressive kids can get aggressive. That's certainly true, but that's not the number one thing that I think most people are concerned about. It's not part of the criteria. There's not a specific criteria about aggression. There is a specific criteria related to suicide. So asking about suicide, if you are a child psychiatrist or any kind of psychiatrist, is not a very stressful thing, because we talk about it all the time. It probably feels like how you guys feel about talking about asthma. Because you talk about it all the time. But when you don't talk about it all the time, I think it can make people feel stressed. And I think sometimes people feel like, is it bad to talk about it, or it's going to make them think about it more? The bottom line is, when you're doing a risk assessment, you have to ask about it. I don't think that there's that much difference in terms of saying suicide versus hurting yourself. Sometimes if you say hurting yourself, people don't necessarily know what you mean. When I talk to kids about whether they have thoughts about hurting themselves or self-harm, I'll often ask them whether they have thoughts about hurting themselves on purpose. Sometimes kids will get confused about what you mean, or there's a little bit of vagueness around it. If you feel like you want to go talk about it that way, you can also just ask whether they've had thoughts about ending their life. If they say, no, I've never had a thought like that, I want to stay alive, I feel really bad, then you're going to still ask a few more questions. If they say they've had any kind of thought about harming themselves, you really want to flesh it out. So you're going to ask them about whether they've had a particular plan in mind. If they say yes, you want to ask for as many details of that plan as possible. Sometimes it's helpful to say, do you have a plan, or did you just think you don't want to live this way, or you can't go on? That can help distinguish a little bit between more the plan and sort of more that passive suicidal ideation, which is still important to know about, but that's going to lower your risk assessment. You want to ask about intent. So how compelled do they feel by the plan? How hard is it to resist? You want to ask about whether there's been, in addition to suicide, thoughts about self-injury. I usually list out different kinds of self-injury because not all kids know what would be included in that. So I usually talk about cutting, burning, hair pulling, skin picking, and then I'll probably say, or anything else like that. Those are the main categories. The hair pulling and the skin picking is not traditionally self-injurious behavior, but if someone's really depressed and they're doing it, they can often do it to a degree that it is self-injurious. So I think it's worthwhile asking it in there. And sometimes you get sort of a sense of like, there was that kind of stuff to begin with, and now it's escalated. You actually may end up observing signs on a physical of prior self-injury that other people haven't seen. Kids will often cut on parts of their body that are usually covered by clothes. So as a pediatrician, you're probably one of the only people who sees a child in this, in the gown in state of undress. So you may see marks, or you may not, but that's just something to think about. So that, and then if you see something, you'd want to ask you sort of what happened with this. Sort of like, thighs and chest, all those places that are really pretty much almost always closed. I think even for Hawaii, those are probably mostly closed. There's not going to be a lot of other explanations. If it's sort of, below the knee or forearms, you could have had some other injury causing it. Kids will sometimes talk about, if they have scratch marks on them, was it related to a pet? You have to think about how realistic that sounds. But anyway, you're going to definitely want to ask about that. You want to ask about any prior suicide attempts. And kids will often start telling you about an attempt, and then it really wasn't an attempt. It was sort of what would have led up to an attempt, but they didn't actually do it. That's fine. You still want to know all about it. You want to know if they've told anyone about it, the timeline of them telling somebody. Did they tell someone the next day? Did they tell someone 5 minutes afterwards? Did they tell someone a week later? Who did they tell? How did they tell? Because you're also going to need to think about, depending on what the prior history was, what you may need to disclose to their parent. And this actually, I probably should have started with that, but you probably had conversations with kids as they go into teenage years, especially about what's private in your office and what you might have to disclose to their parent. So if a kid is coming to you, and then one of the main things people are concerned about up front is that they're depressed, you probably want to set some sort of ground rules about, this is confidential, except, I would have to tell your parent about things if there was an imminent harm to you, or something that was going on recently that was dangerous. I usually say to kids, I'll give you the choice. You can tell your parent or I'll tell your parent, but certain things have to be disclosed. So depending on the seriousness of prior attempts or current thoughts, even if the kid didn't want you to tell them, you'd have to tell. So that's just something to keep in mind when you're listing out all the different things, attempts and so on. A lot of kids, like I said, will talk about that they've made an attempt and actually they sort of did a lot of the parts, but they didn't actually get to the point of an attempt. That's fine. And then unfortunately, a lot of kids, especially with overdose, will have taken some pills and then fortunately nothing bad happened to them, but it's sort of made it seem like it was not as dangerous to them. It is important to ask what kind of pills they took and the number of pills and what they thought would happen. So the younger a child is, the less able they are to assess the real risk of an overdose in particular. So they might have thought, they might take 2 or 3 pills or vitamins, and you're thinking like, that's not really that dangerous. So that's fine. But if they thought it would kill them, then it counts as a suicide attempt. If they took a huge number of pills, then it's really risky regardless. And they probably thought they were going to die. So it's more about smaller things or things that seem milder. How did they think it would actually play out? You really want to ask about means. I mean, I think honestly, hopefully you have decent gun laws out there, but like guns are the number one thing. Guns are the way that you can quickly kill yourself and there's no way back, or you're seriously injured. A lot of other things you can do to yourself. You can get medical attention and survive. Guns are not one of those. So you may already be asking questions with families about guns, but I think you still want to ask again because things could have changed. And now that there's all those ghost gun stuff, it's possible that a child has access to, or a teenager has access to a gun that the parent doesn't know about. Once I hear about a child having thoughts about suicide, if there's a gun in the home, I usually go pretty hard with the parents about, I really want the gun out of the house. You can't make them do it usually, but I really push pretty hard to say, remove it, have somebody else store it. No matter what storage they're doing, it's separate. The kid doesn't know how to open it up. It's in the safe. It's just get it out, put it away for a while where there's no way to get your hands on it. After guns, probably the next most lethal attempt would be hanging, and that's harder to assess means because you can use a lot of stuff for that. So I don't necessarily recommend going on and on about like, well, do you have this in the house and this in the house? But if they've talked about guns, you definitely want to check off. And if they've talked about overdose, you might want to try to find out what they use or what kind of, are there any kind of medications that are in the house that tend to be particularly dangerous? or that are being stockpiled, or what's the access to like medicine cabinets, that kind of thing. There's lots of ways to hurt yourself. So you have to use your judgment about this part, but you want to ask what keeps the patient from acting on their thoughts. So they've had these thoughts and they're in your office, so they're alive. What kept them from doing it? What made them want to make a different choice? Honestly, I usually hear about friends, sometimes your family not wanting to hurt people, pets. A lot of kids will talk about wanting to stay alive for their pets. Sometimes there's an event coming up that they want to live for, which sometimes makes you a little uneasy because you're like, okay, what happens when that's done? But sometimes kids will talk about, well, I want to get to this party, or I want to get to this birthday or this holiday, that kind of thing. But it's good to know what's sort of keeping them from acting on it, and also how future oriented are they. So lots of people have thoughts about self-harm, and they come and they go, and they go through their lives and they're able to manage them. You want to get a sense of how stuck the child, teenager is getting with these. When in doubt, if you're concerned, then you need to send them to an emergency room. I don't know exactly what that would look like for you guys, but I'm sure you have that in mind, because you have to send them to emergency room for other things too, like when you can't get their breathing under control with a nebulizer in the office, the same kind of thing. And I think like I said, one of the links goes to a lot of more Hawaii specific resources. So there's hotlines in there too. So you might want to access those as well. In terms of labs, there are no labs to diagnose depression. People will sometimes talk about getting serotonin levels. Serotonin levels outside of your brain are not helpful, and no one's doing a lumbar puncture to figure out whether you're depressed. But if you're thinking that you might want to start someone on a med, and you're also trying to make sure that you're ruling out any kind of, I would say, other medical condition that could make someone look depressed or contribute to depression, the standard is to do a CBC with DIF, a Chem7, TSH, LFTs, and a urine pregnancy. The LFTs and the urine pregnancy those are more thinking about meds down the road. So you want to try to make sure you're not looking at anemia, any kind of sort of electrolyte imbalance, or I guess if sugar was really high, you might start thinking about, diabetes contributing to mood stuff, thyroid. Like I said, the LFTs are more of a baseline, so that if you decide to move ahead with meds, you have a baseline, and that you could compare afterwards with the psychiatric medications. It's just good practice, I think, if you're concerned about mood changes, to get a urine pregnancy test, because that's something you'd want to know about with or without med trial. I would say have a low threshold to do a urine tox screen. I guess for a fairly young child, I would not do one, but I think tween and up, it's probably worth it. It's pretty easy to get one, and just make sure that there's no substance use as part of this. That's a very common comorbidity. People feel bad and they try to make themselves feel better, and so they'll try drugs. So you're going to want to know about that. But in an otherwise healthy, lower risk teen or child, you don't have to do labs before you start meds. You don't even have to do the LFDs before you start meds. Just, you could. I think in sort of olden days, people did, formally do more meds and have sort of a package. I think, with the pandemic, especially, it's more about like, we're going to move this along. I know for a while I had kids who should have been getting regularly scheduled labs, and I wasn't sending them to the lab because I didn't want to risk a COVID exposure. So the labs are more to sort of give you some baseline, and then to rule a few things out. I have diagnosed kids or picked up hypothyroidism in kids who presented with depression. Anemia is pretty common contributing factor. Honestly, around here, we check vitamin D levels because it's almost always really low, and that can be a factor. I think that's probably not as much of an issue for you guys because you have more sunshine than we do. But in Rhode Island, it's pretty standard for pediatricians to add on a vitamin D level. So that's, I guess you could do that too, but that's, screening scales. So you do not need a screening scale to make a diagnosis. It can be helpful. We referenced for that initial case referenced, they like to use the PHQ-9, the patient health questionnaire, partly because it's free. And I included that link at the end of this. So if you guys want to start using that one, you can use it. It's pretty straightforward. I think it's about 12 questions. But I included a few other ones that you could use that are fairly well-known. The Beck Depression Index, there's a link for it. It's not free. Beck is like one of the big names in cognitive behavioral therapy. So, you could use that. Everyone would sort of know, if everyone in psychiatry would know if you said you did a Beck, that's what you were talking about. But you don't have to use that one unless, I guess, you guys got a great deal on it, or you wanted to start using it or doing a study or something. There's the CDI-2, which is the Children's Depression Inventory 2. That one's also not free. I gave you a link. That the link under the CDI is actually a link for a website that has tons of different screens. So there might be other stuff that ends up being more helpful that you want to poke around there. But basically there's these sort of standard screens. Around here in Rhode Island, people use the PHQ-9 the most. Like I said, because it's free and it allows you kind of not so much, I mean, I think they do them a screening in the pediatrician's offices around here, but then also it's helpful to have them sort of more for monitoring to sort of check and see how are you moving along. So like I said, they're not required to diagnose or monitor, but they may be a useful adjunct, especially if you're the one who's going to be managing depression longer term. So you feel like you have another level. You're talking to the child all the time, you're asking questions, but this is another way. And sometimes kids will, they'll answer the questions on a screen differently than they would talk to you. And then that can give you a place to talk about what's the discrepancy. So kids may sort of, oh, things are fine, but then their screen is actually really bad. And you can sort of circle in and talk about that a bit. I'll be honest, I don't use a PHQ-9 very much when I talk to patients. I actually will just ask kids from 0 to 10. And to give me a sense of where they would, 10 is the worst and 0 is none. If I just want to have a quick sort of sense, because oftentimes the kid will say, oh, I'm fine. And then they'll tell me their depression's a 7 out of 10. And then I can say, well, so tell me about that. What's that difference there? That gives you a sort of sense of things. Younger children who might not be able to use that scale, I'll sometimes say, is your depression, your sadness little, middle, or big? So you don't have to use that, but sometimes it helps. If they're not able to talk about it as much, it helps if you give them a bit of a framework around it and give you a sense about what's the direction that things are going. Okay. Pharmacogenetic testing, yay or nay? So I don't know how big a question this is for you guys, but I imagine you could get asked this question. It comes up a lot for us in child psychiatry. And it's certainly being advertised like all the time, everywhere, and pop-ups and Geno this and Gentech that or whatever. So the bottom line is right now it's nay, I guess. I'm jumping to the answer, it's nay. There's no available testing that's recommended by the American Academy of Child and Adolescent Psychiatry. And there's actually no genetic testing for psychiatric medication that's FDA approved, other than there's a test if you are of Southeast Asian descent and you're going to go on Tegretol because you can have a genetic allele that causes a lethal reaction. But other than that, there's no FDA testing. There's no testing that's FDA approved. So the problem is that the state of pharmacogenetic testing right now doesn't answer the questions we wish it did. It's not going to tell you what med is the one you should choose, and it's not going to tell you the target dose. And that's what you really wish. You wish you could swab their cheek, you put the thing in, and then it would tell you, pick this medicine, and you're going to start at this dose, and this is the dose that'll probably work. Instead, if they come to you with the testing already done, which often happens because they don't have to get it through a doctor's office, you'll get a big packet. It's often color coded. Every single psychiatric medication in the world is listed, and they'll be sort of like green, yellow, and red. And green means go, and yellow means caution, and red means stop. First of all, most of the medications on the list are not relevant to your patient. So that's just confusing to people. What it mostly ends up telling you, supposedly, is sort of how well they process them. So how likely they are to have side effects. But even that's sort of projected. It's not necessarily true. It won't necessarily guide you what you should pick, and it can slow things down. So I never order it. I'm sometimes sort of compelled to go over it with people. Another thing to keep in mind is that all genetic testing right now, this kind of genetic testing, is proprietary. And so you can't, if you've got testing from 2 different companies, you might not get the same results. Is there somebody back there shaking a magic 8-ball and saying, this is your med? I don't know, because it's proprietary. So we're sort of stuck. It's a great idea. At some point, hopefully we'll be able to use it for what we want to use it for, but right now it's not worth it. So if someone comes to you, you can say, no available testing is recommended by the American Academy of Child and Adolescent Psychiatry. If they've already gotten it, fine, whatever. It's not risky to get it, but it's not going to really make a difference for you in terms of guiding treatment. What will make a difference is asking family history questions, which you probably already did when you talked to the parent alone. But I thought this was something I added this slide on because I thought it would be something you could be dealing with on a regular basis. Other forms of testing, neuropsychological testing, which also poses no risk. So this may be helpful if you have questions about learning, ADHD, thought disorder, if there's a lot of talk about trouble with focus, concentration, if there's a lot of focus on decline in school performance, or if there's sort of more, frankly, bizarre presentation, a child who seems very withdrawn, stops doing age-appropriate activities of daily living, hygiene is falling off, where you're kind of getting worried about, is this kid's psychotic? Is she depressed? You don't need neuropsychological testing to diagnose depression. But if you feel like there's something else going on here and you can't quite get a handle on it, it can be very helpful. If you really think you need this testing, then in order to figure out what's going on, then you really are probably going to want to try as soon as possible to get a consultation with a child psychiatrist for ongoing care, because it means things are a lot more complicated. Like I said, you don't need it to confirm the diagnosis of depression, confirm or diagnose. It can be helpful. I actually send a lot of kids for neuropsychological testing. I try to do it strategically, thinking about getting accommodations at school, having things listed out. I find that schools understand tests, and they like to just look at test results, and they will often take things more seriously if there's a big packet that has test results making recommendations versus a doctor writing a letter. There's no particular risk to neuropsych testing. It's not invasive. It's just how long will it take to get. I don't know what the length is. Here, prior to the pandemic, you could often get it done within 3 to 4 months. Now that's stretched out. I know I never send anyone to our children's hospital for testing. They do an excellent job. Prior to the pandemic, they were at least a year out. So I never sent anyone there. But that's something that's more local to you about how quickly you can get it done. Like I said, if you think there's a lot of concern about focus and grades, and you're trying to figure out, well, is this child feeling depressed, lowercase d, because they have ADHD, which is now sort of emerging as a problem, or are they depressed with a big D? And if we treated that, they could focus again. They can sometimes be helpful for that. So there's that. And again, if you're thinking a child is looking really sort of more bizarre or withdrawn, but it's harder to assess psychosis. Honestly, with the timeline, if you really think a child is psychotic, I don't think it's going to be the neuropsych testing that brings it out, but that might be something that you end up seeing on it. Usually when neuropsych testing is done, the neuropsychologist determines what they're looking at. They'll usually do something pretty comprehensive, unless you've already had a set and you're asking to focus in on a particular area. Okay. Treatment options. So like we've determined that this child is depressed, you knew it from the get-go, or you were not sure, but now you are sure. Okay, so what are your options? There's lots of different kinds of therapy. There's individual, family, group, there's medication, there's referring to an ER hospitalization, and then there's what I'm going to call other. We'll talk about some other options that don't fit into one of those. So let's just move ahead with that because I'm trying to keep track of the time here. Individual therapy. Okay, so this would be the standard first step, unless this is a child or teen who's already had a significant trial of therapy in the recent past. So within the past 18 months, they'd already been involved in therapy for 9 of those months, and they had sort of dropped out. You wouldn't say, oh, you have to go back right away. I will say this is the number one thing that probably has changed for me with the pandemic, is that I used to be very strict about, if you're coming to me and you seem depressed, unless I think I'm on the verge of hospitalizing you, if you have not had therapy, I will not start you on a med until you've had 6 to 12 weeks of therapy. But it's gotten to be such a duration of time before you can actually get a therapist around here that I have softened on substantially. And so now I will consider starting a medication trial without a therapy trial or a briefer trial, because once they're in my office, I can treat them, and I don't know how long it's going to be before they can get to see somebody. In your case, you might still try to push the therapy first. You may sometimes have access to a therapist in your office. It depends on what your access is. If you have easy access to a therapist, unless the kid is on the verge of needing to be hospitalized, I think it's good to get them involved in therapy. Therapy alone can be enough. And even if it's not, having a therapist on board who can give you another perspective on how well the patient is doing is helpful. Places to look for individual therapy. So you can look for groups, people who are solo, community mental health centers. Psychology Today, I don't know how accurate it is, but that is sort of a general across the nation. You can look there. Around here, larger groups and mental health centers take insurance, and most people who are solo take cash. It's pretty hard to get an insurance company to work with you they will, but it's difficult as a single person to do that. I will say I had a private practice and I took insurance. I had to hire 2 staff to help me with it. So it was pretty onerous. Larger groups will do it because, economies of scale is not much of an issue. Like I said, prior to the pandemic, I would usually say 6 to 8 weeks for therapy before starting. You should be seeing someone every week, every other week. But now that there are these barriers to access, you could really think you can justify shortening that or just eliminating it altogether. The 2 most common kinds of therapy and individual therapy that your patient is likely to do is cognitive behavioral therapy, which is CBT, or IPT, interpersonal psychotherapy. And those are the 2 that are sort of come up the most. And I included the American Academy Child Adolescent Psychiatry has a practice parameter on the treatment of depression, and those are the 2 that get mentioned the most in the practice parameter. Cognitive behavioral therapy is nice because there are workbooks. The basic idea is that anyone any professional should be able to do CBT because it's manualized. But it's also nice for you as a pediatrician that you can tell them you can go to Amazon or an online bookstore and find a CBT workbook. I don't have a favorite one. Most of them are written by social workers or PhDs. It's a workbook, so you might not want to try to get it out of a library, but they're usually not too expensive, anywhere from $10 to $15. You might end up getting one for your office because then you can make photocopies of things. It's probably copyright stuff, but you can do that. I think a lot of them will have apps now. I'm showing my age because it's all like workbooks and paper, but I do think for a lot of kids, it's helpful to have the workbook. They can write through things. And that way, if there's a delay in getting involved in therapy, they can sometimes start working with the workbook and have something going on, and then you can talk about it with them. If you look through cognitive behavioral therapy workbook, it'll be pretty apparent what's happening. The bottom line of cognitive behavioral therapy is you can't change how you feel directly, so you try to change how you think about things or how you behave, and changing thoughts and behavior can change emotions. So that's the triangle of CBT. Interpersonal therapy is much more about relationships and how different relationships can change your mood, kind of thing, or how those relationships impacts your mood. So those are two that you'd probably hear about the most. Kids who engage in a lot of chronic self-harm will often get referred to DBT, which is dialectical behavior therapy, for which there are also workbooks. That's a different kind. That's more about balancing the desire, the need to change, and acceptance. But that one's not sort of a standard approach for depression. Okay, family therapy. So you already have these people in your office and you're thinking, yeah, they probably could use it. So you could do this in addition to individual therapy, and that would be optimal. And you would optimally have two separate therapists. You'd have an individual therapist and you'd have a family therapist, and they would not be the same person. And the patient and family would be getting all of that. Or sometimes you do the family therapy instead of the individual therapy because the patient's refusing, or if there's some very prominent family dynamic issues that you think are a major contributor to the depression in the child or the teen. So that's something to think about for kids who really don't want to engage and the parents are very upset, very worried, and often rightly so. It can be helpful to start with the family therapy because in family therapy, it's not that the child is always on the spot. It's other people, combinations of people can talk about parents. How can they co-parent effectively to address different issues? So again, in training, I was taught you never have the same individual therapist and family therapist. That's terrible, conflict of interest, patient will never trust them. In reality, often they do trust the individual therapist. They want them to do the family therapy, or vice versa, or you don't have access to two different people. So, you're going to use your clinical judgment on this, but it often doesn't hurt to try using the same person, and then you have to sort of see how it plays out. If you feel like it would be helpful to have someone do some family sessions, sometimes I'll talk about do some individual sessions, and then you can have a family session to kind of do it like a catch up. That's more about, have to have that conversation with a therapist. No one's expecting you to be doing all this therapy. This is more sort of a framework of who else is working with you. Group therapy. So some kids and teenagers find it easier to open up a group therapy. Groups can be kind of one of two things. They can be a group that focuses directly on the disorder. So it's an anxiety group or it's a depression group, or it can be focused on an activity through which you are working on your anxiety or depression or what have you. So my organization specifically has a DBT group focusing on kids with self-harm, but we also are starting a gardening group, and we have a drama group with a local theater company. So those are often age normed. So some groups will be all ages. Often groups will be like 12 and up, or 11 to 14, or under 12. So this will partly depend on what you have available in your area, and sort of finding out about that. Group is probably the least available because it's complicated to set up. Can be really helpful, and a lot of times kids actually do well with it because it doesn't feel like treatment in the same way. It doesn't feel as pathologizing to them, but it can be harder to come by. But I thought it was important to hear about it, and for some kids it makes a big difference. Sometimes I think I don't usually do it as the primary form of therapy, or I don't advise it that way, but it's often a helpful add-on to individual. And sometimes the individual is every 2 weeks, and then the group is every week or every 2 weeks. That way you're getting more regular therapy contact, but not having to have the individual at the same level of intensity. Where my clicker go here? Medications. Now I left not enough time for this, and this is the part that you guys really care about the most. Okay, but you already know some of this. SSRIs. That's what you're going to start with. So there's a little bit of controversy about whether you're supposed to do 2 trials or 3. I'm kind of old school, so I do 3 trials of SSRIs unless I have a really strong reason to switch, because 3 strikes and you're out. So 3 adequate trials of different SSRIs, which means a long enough time at a high enough dose, which means at least 8 weeks, And I usually say at least the midpoint of the range. So for example, Prozac starts at 10 and maxes out at 80. So I usually don't consider it an adequate trial until I hit 40. You have to see that these are either failures because there's a side effect that became a deal breaker, or they were ineffective. If you've done 3 trials of an SSRI, then it's time to move on to a different class. Some people will do 2 SSRIs and then an SNRI, which is like Effexor, Wellbutrin, Cymbalta. That's, I mean, I do the 3. That's partly because I also work with a lot of younger kids. I think with teenagers, it's a little bit easier to justify the 2 trials to the SNRI. Kids around here who go to the hospital almost always go from 2 to the SNRI. They don't do a 3rd trial. The goal is full remission. Hopefully we get there. I'm going to move along through this. Okay, here's a graphic about SSRIs and SNRIs. So the good news is you actually don't have to know every SSRI because we don't use all of them. We use kind of like, I would say the big 3 are fluoxetine, which is Prozac, sertraline, which is Zoloft, and escitalopram, which is Lexapro. Escitalopram and citalopram, Celexa and Lexapro, are like siblings. I almost never use Celexa in favor because I use Lexapro, because Lexapro has a narrower range of doses, so you can get through it faster. And Lexapro is FDA approved for 12 and up. Celexa is not. With both of those, if you hit the max dose, if you wanted to go above, you'd have to get an EKG. So I kind of feel like unless there's a very strong family history of a lot of response to Celexa, then I don't bother with it. And I just use the big 3. Fluoxetine is usually the first choice for people. That's the oldest one, and that one is FDA approved for 8 and up for depression. Sertraline is not FDA approved for depression. It has an FDA approval, I think, for pediatric OCD. It gets used very frequently by child psychiatrists interchangeably. A lot of people actually prefer to start with sertraline for depression because it can be less activating. It's generally pretty well tolerated. So generally just recommend pick one of those. I would say pick for the younger crowd. You're probably going to want to keep the fluoxetine in mind because it's 8 and up. You can say the FDA approval piece. For teenagers, I often will start with the Lexapro because it has fewer doses. It's FDA approved for 12 and up, and it's often helpful when you're in high school to be able to get through that full trial in about 3 months, which you can do with escitalopram. So hopefully, if you need to, you can go back to this, and it also has some little hotlines and stuff. Okay, so Prozac is the oldest one. The other thing to know about Prozac is, so there's a lot of data. It does have the longest half-life. The half-life is 96 hours. It's 5 half-lives to clear. That's 261 hours. I did it once. It's like 60 days. So when you stop Prozac, it's 60 days before it's all the way out. That means you're not going to have a lot of trouble with withdrawal if you miss a dose. That means that if you have side effects with it, it's going to take a long time to clear. So for kids who miss doses, Prozac is often a good one to keep in mind. There's Prozac weekly, but I never use it because it's a pain in the neck with insurance, and regular Prozac is covered and it's cheap. And if you need to, if insurance is an issue, you can get that one usually for $4 or $8 at a grocery store. Lexapro has some perks, right? It's FDA approved if you're 12 and up. It has that narrow range of doses. It's pretty well tolerated. It used to just come in 10s and 20s. Now it comes to as low as a 5. I usually start for kids, no matter how old they are. I take whatever the smallest pill is and I break it in half. Prozac, sertraline, Prozac, Zoloft, and Lexapro, I guess we consistent. They all have a liquid. Now, I guess this says that Lexapro comes in liquid. They do. They don't taste good. And if it says you got to mix it, you got to mix it. If you try, I had a patient once try to take the Zoloft straight without the mixer. It was bad. It stings. So they're not going to want to do it. Paxil, we almost never use in kids and teens. They do not get better with it. A lot of side effects. Luvox is just a pain in the neck. It has a gajillion drug interactions. Mostly people say that for OCD. You guys should not have to be dealing with that. If everyone in the family was on Luvox, I guess you could use it, but otherwise it mostly feels like it was designed to be on board review. The black box warning. I'm going to go through this, like, just going to give you the summary of this. There's several slides about this, so you guys can read them. There's more history of it. The bottom line is there's this black box warning on every single antidepressant if you're under 26, because back in the day, which is in here, there was a trial with Prozac with kids who had moderate to severe depression, and a small but statistically significant number of them reported an increase in suicidal thinking. None of those children went on to make a suicide attempt, and there were no completed suicides. But because it was statistically significant, they put the black box warning on every single antidepressant for kids. Prior to the study, lots of different kinds of doctors prescribed antidepressants. Afterwards, only child psychiatrists felt comfortable doing it. The rate of prescription went down, the rate of teen suicide went up. So there's also this question of, were those kids actually getting worse because of the medication, or were they now talking about suicidal thoughts that they had had before that they had been suppressing or didn't feel like they could talk about. But because of that black box warning, you got to go over it, because if they find out about it, they Googled and you didn't tell them, they'll be really upset, for good reason, but you're going to go over it. You're going to reassure them that it's, this is what the risk looks like. You can go into as much detail as you need. You'll have these slides to look at if you want to review them. I always start at the lowest dose. I always tell people within the first 2 weeks, if you feel worse on it, you can just stop taking it. There's no taper. You can just stop it. You have my permission to go. The standard of care is to be seen within 2 to 3 weeks after the start. I know around here, when we first did this, I did this presentation, the pediatricians were seeing kids 4 or 6 weeks after starting it. And we were like, no, we see them in 2 to 3 weeks. You see them in 2 to 3 weeks. That's the peak time of seeing that side effect. Once you're through that time, it pretty much drops down. Other side effects that you'd be concerned about would be sort of revealing mania, in a child or a teen who is really more bipolar. It's pretty unusual. I guess it happens. The more classic side effects are things like upset stomach, being tired, sleepy, or being more revved up and activated. Sometimes headaches, but oftentimes their headaches get better. So the more common stuff is like the tummies. Okay, so I'm not going to go through all of this. This is how you have these references. You can go back and look at all the details of the black box warning, because I have talked so much that I haven't left my time for you guys. Here's the black box. Here's the impact. We went through that. Okay, so if they did well to a med trial, depending on how easy it is for you to transfer them to somebody else, you could try to transfer them or you could keep them. If a child stabilizes on a medication, then you would keep them on that medication for 6 to 12 months before you discontinued or tapered off. That's the expectation. If people tell me they want to come off before, I never really fight them. But I do talk about the timing of coming off of things. September is a terrible time to come off of med. It's the beginning of the school year. June is a good time or whenever your summer vacation starts, that's a good time. I also try to keep in mind when older adolescents have major things going on, SATs, AP exams, college applications are due, that kind of thing. If your patient is failing the first med trial and you want to try to refer to a child psychiatrist, I think that's fair. I just don't know how much access. We're doing this whole thing so you guys feel empowered to do more of this. So I want you to feel like you can do a couple of these different trials and feel like you have the wherewithal to do that. Okay. I didn't go into great detail about picking another medication, like if you needed to switch ones. There's some information on that graphic about it. I would probably say that if you feel like you need to switch class, I would try to at least do a curbside with a child psychiatrist that you know, just to feel a little bit of sense of reassurance. I usually, if a kid's not sleeping well or not eating well, I use a lot of Remeron, mirtazapine, because that has a histamine component and it tends to help with those things. Effexor can be effective, but it's a bear to get off of. So I don't really love using that one. Cymbalta doesn't have a lot of side effects. It can make kids dizzy. And Wellbutrin is good, but it can make anxiety worse. So that can be a little bit kind of like they little revved up. Okay. If you're really, really worried about this patient, they're actively suicidal, they have a plan, they're in your office, you got to send them to the ER. If they are voluntary, they're like, I don't want to do this, but I feel really unsafe, then you might be able to send them with their parents. If they're refusing or the parent doesn't feel safe transporting them, then you call 911 for an ambulance. Involuntary commitment is state specific. I was trying to look it up. This is where I found the big packet about all the Hawaii resources, because I was having trouble finding it. I think it's a lot easier to get committed in Rhode Island. So in Rhode Island, you can get committed for up to 10 days. I don't think that's the case in Hawaii. All the articles I saw made it seem like it's actually really hard to get committed in Hawaii. But I think that packet will have more details about what your options would be. Around here, we often involuntarily commit kids because there's not a parent available, like it's sort of transient, and it switches over to voluntary. But usually once you're talking about involuntary commitment, the legal system is getting involved, like a judge or a court or something. Okay, other options. I said there's other. So sleep hygiene. Sleep is a big component. Figuring out how well are they sleeping? What are they doing? How late are they on the electronics? What screens are they looking like? What are they doing on the screens? Seems like the good old days. I used to ask people about whether they had a TV in their bedroom. Now that is not an issue. It's always some smaller device. Regular bedtimes. I know teenagers don't really want to do that, but regular bedtimes. Find out about napping. What will often happen is they break their sleep. So they're getting kind of technically enough hours in the day thereabouts, but it's broken up. And so they're not feeling rested in between. So try to consolidate all the sleep tonight. So you say the classic sleep hygiene things. Your bedroom should be used for sleep and sex, depending on how appropriate the sex part is for their age. But try not to do your homework in your room if you can. Try to make your room dark and cool. Try to, go in there at a particular time and you go to sleep. You can use melatonin, Benadryl, or Trazodone. I love Benadryl personally. I love having liquid Benadryl in the house. You can use it for allergies. You can use really little doses. You can get it over the counter. Melatonin, you can get over the counter. I feel like there's more like agita about melatonin, like growth and stuff. I feel like nothing terrible has happened with it because I would have seen it by now. But I think if people are more concerned, you can go the Benadryl route because people are more familiar with that. Trazodone gets used a lot. If you're going to use trazodone and you have a non-binary or male presenting patient, you're going to want to have to talk that risk of priapism. They look at you with goggle eyes. With young women, you don't have to worry about it. I don't use a lot of trazodone. Honestly, I use more melatonin and Benadryl. Talking about daily exercise, regular meals. Here's a perk. Planet Fitness has a free summer pass for 18 to 14-year-olds nationwide. And I think it opened up this week. So I'm just like telling my patients, like, hey, sign up and get it for free if you don't go. You can ask about seasonal components, maybe less of an issue for you guys. For us, it gets really, really dark in the winter, like really dark. So we do a lot more light therapy around here. You also might want to ask with a young woman, I didn't put this on the slide, but ask about correlation with menstrual cycle, and find out how much you're seeing a luteal phase, whether they're on a birth control pill, whether they're open to that, depending on whether you prescribe that or refer them to GYN. That's something to think about. Some people have a very big hormonal component to it, and other people much less so. Sometimes with the hormonal stuff, you can also see migraines, things like that. Okay. Think about comorbid disorders, substance abuse, anxiety, which probably should be at the top. Anxiety, because it's like so common. Trauma, which also, I don't know how. I guess these are all really common. Maybe that's why they're in a row this way. You're going to ask about all these things. Anxiety is probably the one that you would see in the youngest children. It's so prevalent, but all of these things can mix in with depression, and you want to try to assess those. Okay, resources. I told you there'd be stuff. Okay, so this Reach Institute has all these virtual in-person trainings. I got this from my friend, Dr. Welty. She's a pediatrician embedded. She's a child psychiatrist embedded into a big pediatric practice. So that came from her. She also said that they have a lot of luck in her office using the ACAP parent medication guides, which go through, there's one specifically for depression. So you can give this to your patients. They can look at it. She also said the Seattle Children's Primary Care Principles for Mental Health was super helpful. It's a PDF. I looked at it, looked great. So there's that. Here's the PHQ-9. Okay, so that one you can download. It's PDF. There's ACAP has a toolbox of forms. So if you want to look at other kind of forms, I don't know that you actually have to be a member to get them or not. You might not need to, but you can even look for them. And then probably I should have the first one, but the Hawaii Child Adolescent Psychiatry Resources for Primary Care 2019, which when I looked at it made me think, I think someone from that who made that is coming to talk to you at some point. It looks really cool. It's got a ton of stuff, and a lot of it's very Hawaii specific. So that should be helpful. Here we are. It's 6:56 on my clock. Here are the post-test questions.
Oh, I love that last slide, especially. I feel like we should just blast that on our screen at the beginning of the next few months of sessions. I do have 2 questions already that I've been kind of sitting on. So I'm just going to pass those along already.
Okay.
The first one was if you have any updates on most current research on the effects of ketamine in treating hard to treat depression. And then the other one was a question about resources for neuropsychologists for children in the state and outer islands, which would probably be in that link.
I think that link might have some resources for you, or at least would potentially give you a place to call to find out the next level of resources. I can only tell you about Rhode Island. So that one I can't tell you. In terms of ketamine, I don't know anyone who's doing ketamine in kids. These days, there's a little bit of talk, maybe 16 and up. I have a colleague who has a private practice and he's starting a ketamine clinic focusing on adults. But the data is just really not there yet on kids. Child psychiatry, we tend to let the adults do things for a while. I didn't talk about it in great detail because you probably would want to at least consult with a child psychiatrist first. But when kids have repeatedly failed medication trials and they're also not doing well in therapy, you'd probably think about TMS, transcranial magnetic stimulation, in teenagers, which is sort of like, I think of being like ECT light. Instead of using electricity to depolarize your neurons in your brain, it uses magnetism. It doesn't require anesthesia. You sit in a chair for about an hour and you wear a headband and you feel these taps. And it can be very helpful for people who didn't respond to meds or who have any problem with their gut with absorption. I don't know what the resource, the availability in Hawaii would be. I know we have it here and we do treat some adolescents with it, but it usually takes a while to go through the med trials. yeah, ketamine, I don't think I would have to probably look in the Orange book, which is the Child Psychiatry Journal, but I don't think anyone's doing that yet. We're usually sort of like, no drugs, like, get the marijuana out. Like, we're not there with the ketamine. We'll let the adults do that first and see. Any other questions?
Those are the main ones so far. But we do still have the post test to go through. So maybe we can do that next, and then I'll see if anything else comes up in the meantime.
Do we want to give people one last minute to enter their choices, or shall I just start talking about the questions?
I ended the poll.
Okay.
So go ahead and go through the questions.
Okay. So number one, which of the following statements is true? Hopefully I wrote this correctly. It should be that fluoxetine is FDA approved for depression in patients 8 and up. Celexa is not FDA approved for depression in patients 6 and up. Nothing is FDA approved for 6 and up. Sertraline is not FDA approved for depression, and Lexapro is FDA approved for depression in patients 12 and up. So that's that one. So I really wanted you to take away the Prozac FDA approved for 8 and up, because that will give you the widest range of doses, and you can use that. That often will make parents feel more comfortable, but also Prozac is the oldest one. So people have been using that since the 80s, which now is actually a long time ago. Now I think that's like the oldies channel. How heartbreaking is that? So that one you can say, like, look, we can see what's happened with this over time. I will sometimes point out to people, this little pearl of mine, that sertraline is most commonly prescribed by OBGYNs for pregnant women and breastfeeding moms. And so I will point out that if it's okay for a fetus brain to be exposed to Zoloft, that it's, you can think about that for your non-fetal patients once they're out. So that sometimes makes people feel a little bit more comfortable. Number two, after patient response to treatment, where you're seeing improvements, what's the time frame they should remain before tapering off, stopping it? And that is 6 to 12 months, which often seems longer than you would think, but that's a fairly wide range. And again, I often time that to how is that going to coincide with the school year? The standard is that you would do that. You come off the med. If you need to go back on a med, you would then try to stabilize and do it for another 6 to 12 months. If you need a third trial of a medication, whether it's the same medication or a different medication, then you're supposed to stay on it for 12 to 18 months. And then if you've failed to come off an antidepressant 3 times, every time you come off, you relapse, then the recommendation is to stay on it for the foreseeable future. I don't know what that means, so I've decided it means at least 5 years, because that covers a bigger, broader span of time for children and adolescents. Like, that can get you through all of college. Which of the following is a validated screening tool for the use in pediatric depression? It's the PHQ-9, which is also free. The Conners and the Vanderbilt are used for ADHD. I thought you guys might have heard of them. Conners is cost money, and Vanderbilt is free. The Y box I put in because it's the Yale Brown Obsessive Compulsive Index or screen. It was developed here at Brown in concert with Yale, and it's used for OCD. So I put that in there, just, like a little hometown cheer. I didn't want to put the other ones in. The thing that you might find the most helpful is that PHQ-9. Okay. Anything else? Any other questions that emerged while I was babbling?
No, I think that was it, and actually perfect timing on the dot at 1 p.m.
Good. I want to make it home.
Yeah. Well, 7 p.m. your time in that case, I guess. So if any questions do come up in hindsight, everyone, please know that you're all more than welcome to email us anytime at pediatricechohawaii@gmail.com. And I will be looking into getting a few more of the other Hawaii specific resources kind of just collated over the course of the next few months as we continue to have these sessions, to get a really nice list of resources together for all of us. So thank you so much again to everyone who joined us. And of course, an extra special thank you to Dr. Bassen again for calling in all the way from the East Coast. I need to look at our schedule quickly. And our next session is going to be June 1st. We're going to be talking about disruptive behaviors and how to aid parents in managing these kiddos at home. So we're looking forward to seeing you all then and seeing some thank yous going into the chat. And oh, yes.
I'm going to say something very naughty because that's not my presentation, but I've given this resource out a lot. There's a website called livesinthebalance.org by Ross Green, who's a psychologist, and it's all about disruptive kids who would get restrained. So because between now and then, you may see some disruptive kids and you might want to be able to give your patients something. It's a wonderful website. He's written books, but now there's podcasts, there's online training, there's parent support groups. So at the peak of the pandemic, when you couldn't get anyone anywhere, my patients were all in distress. I'm sure yours were too. I cannot stand to have someone in my office or on the phone and not be able to give them something. I gave out that website all the time. And just, even if they didn't find it that helpful, but there's a lot of different ways in with that. There's parts of it that are specific for schools. So if you want to be able to give a parent something while they're waiting to get other treatment, it's a really nice website, livesinthebalance.org. I have no affiliation. I get paid no money. But if it could be helpful, even for one child, one family, I feel like that's great. And, you know, the fact that there's these different modalities, they can read books, they can do podcasts, they can do trainings. There are trainings that are for clinicians too. So I guess you could do a training yourself. But it really comes from a very positive model of like, kids are not bad and parents are not bad, but they need help. So it's I think they call it CPS, collaborative problem solving, I think that's their whole model. So just to have that be, you know, little something heading into June before you get I'm sure it'll be an excellent presentation, but you know, I feel like if I have some little resource, I want to give it to you because I know how hard it is. I'm not a pediatrician, although I did do during my internship, you have to do med repeats. I did 5 months at Hasbro Children's Hospital, and I did pediatric neurology as an extra month. So I had a well child clinic. So I was like, I knew I was going to be a child psychiatrist from the get-go. So I'm with you guys. I want you to have whatever you can. I know you guys are out there. It's like, you know, the U.S. Postal Service, come rain, come shine, no matter what happens, you're there. So I want you to have whatever you can. And if that's something that could help, you know, just to be able to give somebody something, to be able to give them that something to hang on to. Sometimes they can tie them over and then they're through a rough patch and then you can talk with them some more.
That's fantastic. Thank you so much. That's super, super helpful. And I very much agree. I think we're all honestly just craving for whatever resources we can get our hands on, especially during these pandemic times. So thank you so much. I will add that to our list, and Summer added it into the chat as well, but it'll go onto our hopefully at some point very extensive and comprehensive list of all the behavioral health resources we can get. So thank you so much again. Have a great rest of your week, everyone, and we'll see you all June 1st.
Thanks so much.
Thank you. Bye.